So we're hoping that we can show you with these clinical cases that we have selected. Here is a 45-year-old female who presents with obviously a complaint of pain and infection, and you can clearly see the fistula over tooth number 9. This patient is obviously concerned about aesthetics, does not want a removable prosthesis throughout her treatment course, and our referral is ready to perform any restorative procedure that is required based on the end result of surgery. Now, we all hopefully agree that this is a high-risk patient. Why? Number 1, because of the fistula. Number 2, the inherent infection that is going on. And number 3, the radiographic appearance. And Dr. Ganz pointed out that we should highlight the specific slice that is required, as you can see here. Scott, would you?
Yeah, if you take a look at the cross-sectional image that you're seeing here, it tells a completely different story from what you saw in the clinical photograph. And that is, of course, what I've termed in the literature the reality of anatomy. You see the tooth is at the trajectory going completely different from the trajectory of the bone. And as we start to evaluate the alveolus itself, we can identify the facial aspect of the cortical bone and the palate aspect of the cortical bone. And we can also tend to see that the bone within the alveolus is not homogeneous. And so therefore there's areas of more dense bone and less dense bone. And so if we have the ability to have a cross-sectional image and a three-dimensional assessment, we can understand that we can redirect the implant so that it will be placed within the most volume of bone and actually engage perhaps some of the more dense bone, rather than if we did this blindly with a periapical x-ray, which would tell us that we had plenty of bone, and then if we followed the extraction socket, we may be completely out into the vestibule. And so obviously the position of that implant is going to be very, very important in terms of whether or not it's going to have initial stability.
Thank you. So this is what was performed for this patient. The tooth was extracted, obviously, and you can see the reactive granulation tissue that surrounds the root itself. The positioning of the implant during the implant placement or site preparation, as you can see, was aimed more towards the palatal aspect, as Dr. Ganz has pointed out, where the majority of stable bone is located. And once the implant has been placed, we take this measurement and see an ISQ reading of 73-78. Jeff, would you like to comment on this double number?
Well, there's different readings that you get with these Osstell devices, and it depends on the direction that the force is applied to that pin as to whether you're looking at a buccolingual movement or a mesiodistal movement. In this case, I think you're going to show us a little better, but this implant was directed more towards the palate, so there's a gap on the buccal. And that's probably why we have a lower buccolingual movement than we do mesiodistal, because there's good bone contact initially on that plane. So we often see different numbers, and they can differ by a significant number of points. Nonetheless, we want to look at the aggregate and look at the general stability of this, and it's not quite accurate to average these two values, but it is worthwhile knowing them. And if it was a very significant difference, you would take that into account. The other thing that we talked about when we were reviewing this case is you'd like to know some of the drilling conditions as to how this number was arrived at, or how this stability was arrived at. For instance, this implant is probably a 4 millimeter implant, or approximately 4 millimeters in diameter. One very easy way to generate tremendous stability for that implant is to drill a 2 millimeter hole and then force a very large implant into a very small space. You have to know some of the details of this preparation technique and as in interpreting these stability numbers, because you could just be looking at a overcompressed implant into a small space, or in this case, and I think, Peter, you can verify, this was done with a standard drilling protocol with the tapered implant, so that we're looking more at the true density measurements or implications of the density measurements around this implant as it's placed.
Let me just add one more comment, and that is just pay attention to the actual length of the root, because we're going to come back to that in a subsequent case.
Thank you. Okay, everyone pull out their recording devices, because here comes the first question for you to respond to. In this case, the first question is, do you consider an ISQ value in this range to be low stability, medium stability, or high stability?
So 73 to 78 is the values that were obtained in this implant. Does everybody know how to push the button?
Does everyone know how to use the device? I'm sorry, I should have asked.
It may open some garages in the neighboring community, but
It will separate this wall, too, if all of you push one at the same time.
okay. So we have some results, Peter.
And there's the answer. So everyone, well, the majority of us feel that this is a high stability measurement. Some of you feel that it was medium stability. Jeff, Scott, would you like to comment on that?
I'll take it first. Well, obviously, when we as clinicians place an implant, just as Jeff was saying before, we tend to look at what the implant manufacturers have told us over the years, and you look at the designs of the implants as Peter was saying earlier, in terms of getting that initial stability, and we tend to look at torque values, the insertion torque. Now, we understand that the insertion torque is going to give us some tactile information about how tight that implant is going into the bone and how stable it is. But when we start to look at what the resonance frequency analysis gives us, it provides us with an entirely different set of measurements that we can go with. And when you start to look at, let's say, we have 10 clinicians on the left side of the room and 10 on the right side of the room, and we ask them to torque this implant into place, we may get 20 different values related to that initial torque, depending upon the torque wrench that you're using, the implant that you're using, how you ratchet it in. When we're getting an ISQ value, it should be the same for anybody that's making that measurement with this device. And so when we have these types of measurements, we have to start to put those numbers into a reliable scale that has some scientific evidence backing it up that relates what these numbers are to what the actual stability is within that particular site, not just at that time that the implant goes in, but also over time. And we'll get into that in more detail. Jeff?
Just sort of answering this question, I would consider this reading fairly high stability. And one of the things we need to look at on the scale for the ISQ, or the implant stability quotient, is it runs 0 to 100, but it's not a linear scale. It's somewhat logarithmic in a sense. So 70 is not just one more than 69. It is slightly more than that, and it's a curve that increases. So I would consider this a fairly high stability.
That's a very good point. Do either one of you have a cutoff point as far as between medium to high? Is there a certain number that you would consider the cutoff point for being medium?
I would say that anything that's above 70 is going to give us the confidence to be able to know that that implant is stable, and we can, in fact, make a decision on loading that implant at the time that is placed. Anything, to me, that's going to be probably above 75, 76, I think is going to give us much more, as Jeff said, it's a logarithmic scale, so it's not linear. And therefore, for me, anything above, let's say, 76, I think is going to be a much higher degree of stability than 70 would.
Would you agree with that, Jeff? Or?
Well, my cutoff for medium would probably be low 60s, 62, 63. So medium high would be mid 60s up to low 70s, and I think anything above about 70 And I'm contradicting myself a little bit there, but anything above 70 I would consider fairly high.
Thank you. Next
But
question.
can I also say that in the literature, again, this is scientifically based. There's evidence with more than 600 articles in the literature, and one of them, going back to what was stated, Turleman and McGlumphley in their group were talking about undersizing the osteotomy to improve implant stability, and that particular article that was published in 2008 shows that there is a difference in the ISQ values. And so we can put this into different clinical situations, but one thing that we have to also consider is that these cases don't exist just because of that implant. We have to take the totality of the case, the occlusion, and all of the other aspects that go into the single tooth, where it is, the patient's habits, whether they're bruxers, et cetera, to be able to understand the true clinical implications.
So our next question is, this ISQ value of 73 over 78 would give me the confidence to A, submerge it, B, leave it exposed with a healing abutment, or C, immediately load. And for my advanced clinical training students, you better answer this right. So can the ISQ numbers give us the confidence to provide a certain loading protocol? Jeff?
I think the ISQ is part of the information that you need to evaluate when you're deciding on a loading protocol. Scott touched on some of that already, and just to reiterate, I think one of them is, how did you get to this point? Was you dramatically undersizing the osteotomy? You'd like to know tissue quality, the aesthetic risk or the aesthetic sensitivity of this particular patient, location in the mouth, your ability to control forces on this implant, because regardless of how it's loaded, it cannot move during the healing process, or you will ruin the osseointegration. So I would like to have a high ISQ value, but I'd also like to have all of these other factors working in my favor in order to move on to an immediate restoration or an immediate loading scenario.
So,
I just want to add that I would say that when we have a value that we can hang our hat on, it gives me certainly some clinical relevance to what we're doing and helps us to be able to make those decisions. Without question, it is an incredible way of taking the guesswork out of what we're doing.
So as you can see here, we did take into account everything that Dr. Ganeles has pointed out as far as the management of the soft tissue. We did, in fact, immediately provisionalize, but also notice the incisal position of that provisional, how we have reduced it to try to take it out of at least contact. I don't want to say out of occlusion, because we all know that no matter how low you reduce that position, whenever a patient bites into a bolus of food or, in fact, speaking, there's going to be occlusal contact. So what we're trying to do is just to minimize that, the strength of that contact. So you see at 6 months, soft tissue has healed up beautifully. And at this point, we're taking our second ISQ measurement. When we remove that provisional restoration, you can see the nice detail as far as the soft tissue contours are concerned, and the development or the maturation of the transmucosal tissue around the provisional as well as the abutment. Now, this next ISQ measurement we see is 84. So at this point, we feel confident that it would be appropriate then to proceed with the definitive restoration. And this is what you see here. So from the beginning to the end result. Again, relying on our ISQ measurements to help guide our clinical protocols as far as the loading approach is concerned. Here's the second case. Very
Can you go
similar.
back?
I'm sorry.
There's, I wanted to comment a little bit about the really nice result that we see here. And I believe that one of the reasons that this was almost invisible dentistry, meaning you can't really tell what was done here, is because as part of the procedure, the original tissue contours were preserved. They weren't recreated by provisional placement or by developing contours, etc. They were preserved in the first place. And we can see that if you look at the most difficult spot for me to manage, which would be the papilla between the central and lateral incisor. There's symmetry in this case. The right side looks like the left side. And I have tried, as I'm sure everybody in this room has, to recreate this in delayed loading protocols, and it's extremely difficult. On the other hand, if you can immediately load with confidence and having a measurable stability is part of that confidence, if you can immediately restore this and preserve those tissue contours, you get a better result. So having the ability to know what you're dealing with and to sort of monitor the healing of that implant along the way allows you, I think, to have a superior result than what we might have done in a staged approach. And I think this case and the next one that you're going to show us sort of highlights an advantage of being able to do this type of treatment.